நான் அனுப்புறேன்மா. இதுல வயர்லெஸ்ல அனுப்புறேன் காப்பி.
Yes, ma'am. Done, ma'am. Sorry, ma'am. My network
yes.
is a problem. Sorry.
No problem. Good evening to
Yes,
all.
ma'am.
First of all, I welcome all the delegate students and teachers for our third TNFOG Bodhana PG class. Today's topic is on previous LSCS. For this, we have the coordinator, Dr. Kalpana. So I request Kalpana to start the program.
Trakala, I will share the screen, no problem. You
Kalpana,
Okay, ma'am. Thank you.
Okay. Good evening, everyone. This PG training course has been initiated by TNFOG. It would be really useful for the PGs. We have learned experts, experienced teachers who will share their knowledge and valuable experience here. Repeated case presentation would be really helpful for their PGs for their examinations. And in addition to reading, discussion would help them to think in a different perspective. So we have an interesting case, previous LSCS. May I now welcome Anjalakshi Madam, President TNFOG, Founder President TNFOG.
Enough, Kalpana, enough. No, because already we are 15 minutes late.
Okay. I welcome our internal examiners, Anuradha ma'am, who is a HOD in Chettinad Medical College and with huge teaching experience. She has won various awards like Best Doctor Award from Kilpak Medical College and gold medalist in the final year. And the other internal we have is Vijayalakshmi Madam, who is a professor in Chettinad Hospital and Research Institute and with 16 years of teaching experience. Ex-executive member OGSI, and we have externals, Girijabag Madam, who is a professor in Bharati Vidyapith Medical Hospital, Pune, and she's a senior consultant Cloud9 and Apollo Hospitals, Pune. And
Hello, hi. Fine. Yes, welcome, Girija.
Hi.
She was a chairman Medical Disorder Pregnancy Committee 12 to 16, Vice President India Chapter Gestosis since 2014, member of Gauni Council member ICOG 11 to 14, Joint National Secretary FOGSI 2010, Assistant Coordinator National Eclampsia Registry since 2008. And she has won various awards. The other external examiner is Katpagam Madam, who is assistant professor in KAPB Medical College, Trichy, 2004 to 16, and associate professor in Chengalpat, 16 to 20, associate professor in KAPB from 2020. Undergraduate teacher and examiner since 2004, postgraduate teacher and 2007, published various papers in international journals. The presenter is Sherin Almash, who is going to present about previous LSCS. Over to you.
Kalpana, before she starts the presentation, as a president, let me complete the welcome address. I'm very happy that this Bodhana program is going on very successfully, and I request all the postgraduates to make use of this. They extract all the knowledge from the experienced and renowned teachers. So I welcome the teachers from inside, Dr. Anuradha, who is a very eminent teacher. You will know that when she talks, and Dr. Vijayalakshmi, again now she is a good teacher, and you have the external teachers, Dr. Girijabag, and who is the chairperson for the medical disorder. So you know the capacity of Girijabag, and also Dr. Katpagam, who is a very good teacher. So I welcome all the teachers, and I welcome this presenter to present the case and clarify all the postgraduates. Please clarify all your doubts No, don't bother whether it is silly or it is worth asking. All those feelings, you please don't have. Whatever doubt arises, please make clear from the experienced teachers. I once again welcome the teachers and please go on. Thank you.
Thank you so much, madam, for your welcome address. May I now request the presenter to present the case?
Good evening, ma'am. Shall I start?
Sharon, you can start sharing your screen, ma'am.
Yes, ma'am. Ma'am, is my screen visible, ma'am?
Yes, it's visible.
So today's topic is previous LSCS. Case scenario, Mrs. S, 26 years old, Gravida 2 Para 1 Live 1, a housewife from Kelambakam belonging to class 3 socio-economic status. She's booked
Please
in.
open your video, Sharon.
Yes, ma'am. She is booked and immunized at Chettinad Hospital. Period of gestation is 38 weeks in two days. Gravida 2 Para 1 Live 1 at 38 plus 2 weeks of gestation came for antenatal checkup. She is able to perceive fetal movements well. No history of abdomen pain, bleeding PV and leaking PV. Menstrual history. Age of, ma'am, 1 second, ma'am. I have opened the old PPT, ma'am. Ma'am, is my screen visible now, ma'am?
Yes, yes.
Just open and give me PPT. Not able to open. Yes, ma'am. Menstrual history, age of attainment of menarche, 13 years, regular cycles once in every 28 days, normal flow lasting for 3 to 4 days, changing 3 pads per day, no history of passage of clots or dysmenorrhea. LMP is 18/2/2021, EDD is 25/11/2021. Marital history, married for 5 years and non-consanguineous marriage. First time obstetric history, present pregnancy, first trimester, spontaneous conception confirmed after 55 days of amenorrhea at hospital by urine pregnancy test. Folic acid supplementation taken. Dating scan done at 2 months of amenorrhea and pregnancy confirmed in corresponding to dates. No history of fever with rash. No history of hyperemesis gravidarum. No history of spotting or bleeding PV. No history of abdomen pain. No history of increased frequency of urination or burning milk derision. No history of exposure to radiation or drug intake. She has taken 2 antenatal visits in first trimester. The weight gain in first trimester was 1.5 kg. Second trimester, quickening was felt at 18 weeks of gestation. 2 doses of tetanus toxoid were taken. Iron and calcium tablets were taken regularly. Anomaly scan was done and found to be normal. No history of GDM. The DIPSI value at 26 weeks was 115 milligrams per deciliter. No history of fever, increased frequency of urination or burning milk derision. No history of pedal edema, blurring of vision, epigastric pain or headache. No history of abdomen pain or leaking PV or bleeding PV. The weight gain in second trimester was 3.5 kgs. Regular antenatal visits were taken. Third trimester, she continued to perceive fetal movements well. Iron and calcium tablets taken regularly. Growth scan was done and found to be normal. No history of increased frequency of urination or burning milk derision. No history of pedal edema, blurring of vision or headache. No history of pain, abdomen, leaking or bleeding PV. Weight gain in third trimester was 4.5 kgs. History of previous pregnancy. Antenatal events were uneventful. She was a booked case at Chengalpet GH. Perinatal events, Term baby, institutional delivery by C-section 3 years ago. The indication was breech presentation. Outcome, she delivered alive boy baby of 3 kg birth weight, cried immediately after birth, currently healthy and doing well. Puerperium and postnatal events. No history of fever, foul-smelling lochia, or wound discharge in the post-operative period. Catheter removal was done at 12 hours post-operative period. No history of blood transfusion. She was discharged on 5th post-operative day. Suture removal done on 7th POD, and no history of resuturing. The interpregnancy interval was 3 years. Contraceptive history. OCPs taken after first pregnancy. Past history, not a known case of hypertension, diabetes, asthma, TB, epilepsy. No history of blood transfusion in the past. No history of any recent surgeries. Family history, no history of hypertension, diabetes, asthma, tuberculosis, epilepsy. No history of bleeding disorders in the family. No history of children with chromosomal anomalies or birth defects. No history of twinning in the family. Personal history, she takes mixed diet, normal appetite, adequate sleep, bowel and bladder habits normal, no history of substance abuse. General physical examination, is moderately built and well nourished, afebrile, no pallor, icterus, cyanosis, lymphadenopathy, and edema. Height is 160 centimeters. Pre-pregnancy weight is 62 kg. Present weight is 71.5 kg. So weight gain in pregnancy is 9.5 kgs. The BMI with pre-pregnancy weight is 24 kgs per meter square. Vitals, pulse 90 per minute, regular rhythm, normal volume and character. Blood pressure 120/80 millimeters of mercury, measured in right arm in sitting position. Respiratory rates 16 per minute. Obstetric examination. Examine in supine position with legs semi-flexed. Inspection. Shape of the abdomen is longitudinally enlarged with fullness of lungs. Umbilicus is everted. Linea nigra present. Stria gravidarum present. No sinuses or dilated veins. Hernial orifice is free. A horizontal scar of 10 centimeters noted. About 2 to 3 centimeters above pubic symphysis. Healed by primary intention without hypertrophy and keloid formation. No incisional hernia over the scar site. Palpation. Symphysiofundal height corresponds to is 38 centimeters. Abdominal girth is 101 centimeters at the level of umbilicus. The obstetrical grips, fundal grip, broad, soft, irregular mass suggestive of breech. Left lateral grip, uniform curved resistance, felt suggestive of spine. Right lateral grip, multiple nodular structures felt suggestive of fetal limb parts. First pelvic grip, hard independently ballotable mass felt suggestive of fetal head. Second pelvic grip, fingers converging and fetus in flexed attitude. No scar tenderness, clinically adequate Leica. Auscultation, fetal heart rate felt along the left spino-umbilical line. The heart rate is 142 beats per minute. Provisional diagnosis, a 26-year-old gravida 2 para 1 live 1 at 38 plus 2 weeks of gestation with singleton live intrauterine pregnancy, longitudinal live and cephalic presentation with previous cesarean section not in labor.
So how are you going to manage this patient?
Ma'am, she is gravida 2 para 1 live 1. The 38 plus 2 weeks now. The previous indication for the C-section is non-recurrent indication, which is breech. Also, the interpregnancy interval is more than 18 months, so 3 years back. So I would like to counsel her for VBAC after informing all the risks and benefits of both VBAC and elective repeat C-section. And in a tertiary care hospital with all the facilities for multidisciplinary team management, including anesthetists, blood bank facilities for emergency section, everything. If after getting appropriate consent and documentation.
So this counseling for VBAC should be done when?
Ma'am, ideally for the second gravida should be done in the first antenatal visit itself, ma'am.
In the
First antenatal
yes.
visit.
As soon as you see the patient, so you have to prepare her mentally for the vaginal delivery, right? Yes. What are the investigations you would want to do?
The routine investigations like complete background, grouping, typing, serology, urine routine, the RFT, and DIPSI, ma'am, and so not ultrasound for the scar thickness, ma'am.
So what do you find out by this ultrasound?
We can see the scar.
Is it only for the scar?
For the
thickness?
estimated fetal weight, the placental location, the amniotic fluid index, the lie, the position, the lie, ma'am. Placental.
Okay, can I ask you a question?
Yes, ma'am.
Hello?
Ma'am, am I audible, ma'am?
Yeah, I can hear you. Can you hear me?
Yes, ma'am.
What was the reason why the C-section was done in a previous pregnancy?
Breech presentation, ma'am.
Can you be a little louder, Sherin?
Breech presentation, ma'am.
So was it a term
It was a term breech, ma'am.
elective or emergency?
Elective breech, ma'am.
So at what gestational age was it done?
Ma'am, at around 38 weeks, ma'am.
At 38 weeks.
38 plus. I'm not able to get those details from the patient. So
Okay, so now if you have a patient who has come to you for with a history of previous C-section, what should be your sonography surveillance during the antenatal period and the rationale? What should be your ideal sonography surveillance?
ma'am, for this trimester, ma'am, now.
I said, please listen to the question carefully. A patient of previous section has come to you for antenatal care. Throughout the antenatal period, what should be your antenatal surveillance sonography wise, especially sonography in context?
From the dating scan, right from the dates, if it is corresponding or not. Then
Okay.
in the NT scan.
Anything at the time of dating scan that you would look for if you are doing a sonography in a previous section, or you will recommend, or you will write on the paper?
Singleton pregnancy.
So that we see for everybody, na? Especially with a previous C-section.
She is a primary gravida and she had a breech. It was a malpresentation in her primary pregnancy, isn't it? First pregnancy. So during the dating scan of her second pregnancy, what else would you like to see? That is what madam wants from you.
Uterine anomaly.
One is uterine anomaly. Anything else? What is the biggest risk now a patient of previous section carries in a subsequent pregnancy? Can you think of that, beta?
Scar thickness in the.
Oh, scar thickness is not a thing here. What is important? Very life-threatening. What is the life-threatening thing nowadays we are very concerned about?
Scar pregnancy.
Scar pregnancies.
Or a scar pregnancy? Okay, fine. More than that, morbidly adherent placenta in the future, right?
Yes, ma'am.
So in the dating scan, is it important to see where the implantation is occurring?
Yes, ma'am.
Yeah?
Yes,
Okay. What at 12-week scan? What would you like to see at the 12-week scan?
Again, placental localization and NT.
Yeah. So placental localization at every surveillance has to be seen. And you have to, if it's a low-lying placenta, you will have to keep a follow-up on that, isn't it? Okay. My questions are done. Yeah.
It's not visible.
Madam, Girija, madam, your question is over.
Yes, my question is over. My question is over.
So, in this ultrasound, placental position you are seeing, isn't it? Is there anything important you want to rule out regarding the especially anterior placed placenta
Ma'am,
in your ultrasound? What are you worried about?
Morbidly adherent.
Apart from the scar integrity, one more thing we have to see.
Morbidly adherent placentas. I mean.
So whether it is adherent or not. Do you want some complementary test for that also?
The Doppler.
Very sure.
Doppler.
Doppler. Anything else?
MRI also can be.
MRI. So MRI will be more
Sense.
definitive for this. Right. If you are going to decide on vaginal birth in this case, since it's a non-recurring indication, you said her LCB is 3 years. So you are going to counsel her for a vaginal delivery. When are you going to assess her pelvis?
After 37 weeks, we can assess the pelvis, ma'am. If it is.
You will assess the pelvis.
Yes, ma'am.
So, any other time you want to reassess?
During labor also we can reassess.
During labor also. So, what are the points during labor that helps you in delivery? Why do you want to reassess during labor?
To rule out major CPD, I mean moderate CPD.
Major CPD we are not going to.
Moderate CPD.
So we are very sure that it is an adequate pelvis. Maybe. So if you want to reassess in active labor, preferably of course, all this VBAC should be spontaneous vaginal delivery. So suppose you have a doubt, what are the additional factors during labor that is helping the baby to deliver?
In other words, what are the factors in labor that helps her to have a successful VBAC?
What are the favorable points? In other words,
cervical dilatation, uterine contractions, spontaneous onset of labor.
So spontaneous onset is always preferred. Okay. It is always safer also.
The cervical dilatation.
Cervical dilatation.
Okay. The length of the cervix.
Okay. You can divide it into passage, passenger, and forces. If you remember like that, I think you can tell me the points.
Yes,
so what happens to the passage?
Mahati, you can answer.
Yes, ma'am. Power, passage, and passenger, ma'am.
Yes.
Should I mute it?
Okay.
Pelvis has to be assessed.
Yes.
1 minute, ma'am. Pelvis has to be assessed, ma'am. That is at the level of brim, and mid pelvis and outlet has to be assessed. Sacral promontory shouldn't be reached, ma'am. At the level of mid pelvis, ischial spine, sacrosciatic notch, and side walls have to be seen. At the outlet, we see subpubic angle, subpubic arch, and transverse of the outlet, ma'am.
1 minute, Karpagam, 1 minute. If the presentation is over, means you can stop sharing, I think, ma. Such that you can see the video of remaining presenters. Mahati, Rizwana, Nandini, please open your video. Yes, Karpagam, proceed.
I am not able to see the PG who is presenting.
Madam,
Please give me the answer.
what is the favorable points? I will give you a flow, the station of the head when you are examining the case. Favorable points, would you already told? Spontaneous onset, I agreed. What are the other favorable points? Then you will be happy.
Who is answering, Sherin?
Sherin, you can answer, ma. What are the favorable points?
So to know that your labor is progressing well now.
Adequate dilatation
Good
and descent
cervical
of the head.
dilatation, descent. You
Well
have
applied
adequate,
head.
good uterine contractions.
No early engagement, well applied cervix. These are all the favorable points. No, would you
And
be
also
happy
the
if I
fetus is trying to negotiate. Fetus also undergoes certain changes. The pelvis also undergoes certain, it tries to give way. I've given you all the answer. The give of the pelvis. And the passenger, the fetus also, there's a certain amount of molding, caput, which is trying to negotiate and good uterine contractions. Okay, that is okay. So VBAC, you're going to conduct VBAC. So what are the precautions you have to take for the mother and the fetus?
Precautions for VBAC, ma'am.
What will you do when you are giving a trial of labor after the cesarean, isn't it? So now she's undergoing a TOLAC. The trial is going on. How will you monitor the mother? That is what madam wants from you. Say stage wise. Stage wise, you give your answer properly.
Stage 1, 2, 3.
First stage, continuous CTG monitoring is advised.
Yes.
One-to-one, preferably one-to-one monitoring, and for every 15 minutes to half an hour, FH and scar integrity should be checked.
Scar integrity, how can you check?
Ma'am, scar tenderness has to be checked, ma'am.
Will that be the earliest sign for you?
The earliest sign of CTG changes.
What would it be before the scar tenderness?
Tachycardia, the
What
BP
tachycardia? Tachycardia of the mother?
maternal tachycardia, ma'am.
Maternal and?
Fetal also.
Fetal tachycardia. Okay. So you'll be monitoring the CTG as well as the. And then
what else will you do for the mother? You said you will.
IV line for blood investigations, and blood for cross matching can be collected. Epidural analgesia can be.
You want to have the help of someone? You want to inform?
The anesthetist and the pediatrician, the blood bank.
The theatre must be ready. Always it is done under double setup, isn't it? Proceed.
And also scar tenderness has to be checked. In second stage, continuous fetal monitoring, and scar tenderness has to be checked after every contraction, and cut short the second stage by outlet forceps or vacuum. In third stage, active management of third stage of labor has to be done. And fourth stage, a patient has to be observed at least for 4 hours.
Third stage, anything else you're worried about?
Manual tumors should not.
Third stage, placental delivery.
No, should not attempt manual.
What about the urine?
Ma'am?
The color of urine is important?
Yes, ma'am. Impending rupture, hematuria.
So even in the third stage, even after delivery of the placenta, there are chances that it may be identified. So what are the signs to say that rupture has occurred? Or a dehiscence or rupture has occurred? Especially rupture, that only will have a catastrophic sign.
Maternal tachycardia, fresh bout of bleeding PV. Suprapubic bulge may be present. Incoordinated uterine contractions. If it is rupture, sudden cessation of the uterine contractions, and loss of station, hematuria.
So you have to immediately shift to the theatre. So what is the difference between, it's a very simple question, dehiscence and rupture?
Partial rupture is scar dehiscence, where the visceral peritoneum is intact, where all the 3 layers are given away. That is rupture, ma'am. The fetus can be alive or dead in dehiscence. Here it is.
Depends upon how fast you take up for section and how fast you finish. Your baby may be alive or you may have lost. Okay. So suppose, do you always do a hysterectomy in rupture, or would you like to do a rent?
Repairable rent we can repair. If it is not repairable and ongoing blood loss is there, then hysterectomy has to be done. Rent can be repaired with delayed absorbable suture.
Okay. This rent closure, would you advise anything else along with the rent?
Along with the rent, we have to do sterilization, ma'am.
So we have to advise, get the consent and do sterilization, right? So this trial of labor. Suppose, who are the patients who are favorable for trial of labor after cesarean section, and whom are you going to go for elective cesarean section? Favorable factors.
So, previous one LSCS and cephalic presentation, average size baby weight, and in the interpregnancy interval if it is less than 18 months, sorry, more than 18 months.
More than 18 months.
And
Does any post-operative history influence your delivery decision in the previous C-section? What are the pertinent histories in the previous C-section delivery that you would look for, which may influence your decision whether it's going to be a VBAC or whether it's going to be a repeat elective C-section?
yes, ma'am. History of puerperal pyrexia, foul smelling, lochia.
Puerperal pyrexia alone, will it influence? Only puerperal pyrexia. Puerperal pyrexia can be a transient thing, occurring only one episode. Will that determine that you will decide not to give her a vaginal?
Because if it is associated with foul smelling lochia,
See, puerperal foul smelling lochia, puerperal sepsis, and puerperal pyrexia. These are three different entities. Don't mix them all up. You understand? Foul smelling lochia does not essentially mean puerperal sepsis. Are you understanding? It can be a hygiene issue also. So yes, I'm understanding. You are trying to say that probably if you would be concerned about the healing of the previous scar, if that is questionable, then you may consider to consider a elective section. That is the answer that you want to give. Anything else in her post-op period in the previous surgery that is of concern, pertinent history that you must ask?
any history of blood transfusion, anemia.
Okay.
Anemia will cause poor wound healing. So,
Okay. Okay. Then
catheter removal day.
yeah. So what is that? How is that? What is the rationale?
In case of obstructed labor, prolonged catheterization would have been done.
One is obstructed labor. Anything else which is necessitating a prolonged catheterization, patient would tell you, I underwent a C-section. This was an elective section, no co-obstruction, no bladder injury. So now if a patient has given you a history of being under catheterization care for about 7 days in a previous pregnancy, so then would you consider her for a VBAC in her subsequent pregnancy?
Ma'am, can consider, ma'am, based on the interpregnancy interval.
Yeah, interpregnancy interval maybe, and if you have the details, but then it's always better to safeguard. So if you have the details, fine. Now in the past, and there are some studies which are saying that whenever you have any doubt about the scar or the scar being extended, scar integrity under doubt, any injury, in such doubt situations, you may consider doing a elective repeat C-section. Are you understand?
Yes, ma'am.
So therefore, when we tell you, now if you, for example, were doing that C-section and the baby was delivering by breech and you could not deliver that baby, and you decided to extend that incision, you decided to extend it vertically. You took a T-shaped incision, isn't it? So in that situation, this patient going into a VBAC in the next pregnancy can be hazardous. She may go into sure shot, maybe scar dehiscence or rupture.
Yes, ma'am.
So what is our responsibility when we do such a thing?
So, better to counsel her for
either document it on the paper, or
document.
if you are worried about documentation, you can at least definitely tell the patient that next time opt for a elective cesarean delivery.
Yes, ma'am.
You understand? So these are the things which we should know. Okay, so madam was asking you about scar integrity.
Yes, ma'am.
Madam, I was asking about conditions favorable for trial of labor.
For trial of labor. So basically it is scar integrity.
Yes,
It's a trial of scar.
Trial of scar.
What's the scar thickness?
First and foremost, Sherin, since when are you coughing, baby?
Ma'am, this is GERD, ma'am. I have GERD problems. So.
You have GERD problem, but don't get it, please go and find out whether you are also suffering from COVID or not. Don't take it lightly. Yeah.
Yes, when you are coughing, we are afraid.
Yeah, we are
Whether you are
afraid.
artificial.
Even today, 2 students who I was taking terminal examination for UG, and 2 students were coughing so badly. I said, right now you're going to go down and do, and both of them came COVID positive. Okay, don't take it lightly. I'm telling you, post vaccination also COVID is happening. Okay, I don't want to scare you better, huh? Yeah.
No, you should scare her. Then only she will take.
Yeah.
Yes, proceed.
Ma'am,
Rishwana, Mahati, you can answer. Why you people are not opening the video?
Rizwana and Magati is not answering now.
Nandini, anyone can answer, and other students you can put whatever your doubt in the chat box.
Yes, ma'am.
Waiting for the first.
Okay, so conducive factors. Have you finished all the conducive factors that madam was asking you for allowing a VBAC? Anything else you want to tell us?
Sherry, you have completed or anybody else is answering?
Mahati was answering.
Yes? You completed? Sherry,
Ma'am, which question?
previous non-recurring indication, 2 or 3 you have already told, I think.
Yes, ma'am.
Yes? Okay. So who are the people who are going to plan for elective cesarean section at term? These are people who do not want to give a trial of labor. So you want to do an elective cesarean section at term. What sort of patients are they?
Ma'am, can you repeat, ma'am? There was break in the voice.
Who are the candidates for elective cesarean section at term?
Okay, ma'am.
Right.
Previous classical.
There is a group whom you can allow for vaginal delivery. There is a group you definitely say no, you have to go for section.
Previous classical C-section, previous 2 C-section, more than or equal to 2 LSCS, and hysterotomy, previous metroplasties, all those. Contracted pelvis, major CPD, placenta previa, major grade 3, grade 4.
Madam also told about the post-operative period.
Bladder, previous history
I
of
not see any infections.
infections, endometritis.
So her previous obstetric history, especially the postnatal period, is important to decide. And another thing was all this inverted T, J, everything. We should warn the patient and mention in our notes if possible. Otherwise, we will not know what sort of incision is inside, even previous hysterotomy. So, all this should be proper discharge summary. The importance of the proper discharge summary you can see in these cases, isn't it?
Yes, ma'am.
So, okay. So, when will you do this elective cesarean section? At how many weeks?
Ma'am, if it
You
is
decide to do.
if it is a classical C-section, we'll admit her at 36 weeks. If it is lower segment C-section, we can admit
36 weeks itself.
36.
The neonatologist, the pediatrician will be very angry with you. Giving them all.
For the classical C-section, we have to admit earlier, ma'am. For the lower segment, we can.
Okay, earlier I agreed. The
Classical is extremely rare, Sharon. So please don't discuss about something that is a very, very rare event. Talk about, see, almost 100% adherence to lower segment C-section only is going on.
So your hospital will be having a protocol. At how many weeks?
39 weeks.
39 weeks.
Yes. 39 weeks. Yes. So you'll plan for elective cesarean section at 39 weeks. All right. So in this previous cesarean section, non-recurring indications, the timing of section, is it important? When the cesarean was done, during which gestational age?
Yes, ma'am.
How does it affect the subsequent?
If it is a preterm in delivery, the lower uterine segment would not have well developed. So most likely the incision would have extended to the upper segment, and poor wound healing also. The chances of scar rupture is more in this subsequent pregnancy.
So the timing, the gestation age, which was done, is also important. Okay. You talked about classical cesarean section. What are the indications for classical cesarean section in modern obstetrics? Any indications?
In case of transverse lie, advanced CA cervix, or any tumors in the lower uterine, fibroid in the lower uterine segment, placenta previa, and conjoined twins, difficult dense adhesions in the lower uterine segment, impairing the vision.
So placenta previa, especially placenta
Previa.
previa matol.
Morbidly, placenta accreta,
Adherent placenta. So in an adherent placenta, we definitely have to put the incision over the upper segment. So how do you deliver the baby in a classical cesarean section?
Ma'am, it is
Very rare procedure, of course, but still under certain conditions we are forced to do. These are the conditions which you have already mentioned. And if you see now, there is an increasing trend for placenta previa because our primary section rate has become very high. So almost every institution is having more than 30%. The reason why this primary section rate is rising?
because of the because of the continuous CTG monitoring and decrease in the VBAC. Also, all the primary breach are delivered by LSCS after the term breach trial, and also because of the advanced maternal age and precious pregnancy.
Precious baby, advanced age, and of course the safety offered for cesarean section. Sometimes it is also for a maternal request. So all this, what happens? The increased incidence of placenta previa we are seeing nowadays, and also morbidly adherent placenta. So you can see the importance of us reducing primary section, right? So since we were talking about classical cesarean section, so apart from this, in your previous lower segment cesarean section. Okay. So there are various methods of closure. So does it affect the outcome in the subsequent pregnancy?
No, ma'am, there is no difference between single layer or double layer closure. Even locking and interlocking depends on the.
So there is no significance.
So what is the principle of suturing that you should follow, Shereen? It's fine. This doesn't work, that doesn't work. But what would be your ideal method of suturing? What will be the tips that you will follow? Because you must be doing a lot of C-sections now. And you must ensure that your patient should not come with morbidly adherent placenta next time. So what are the things that you will do? There are some important, at least 5 tips you tell us.
A perfect apposition should be there without inclusion of decidua. And
is the decidua having any evidence to support what you are saying? The decidua again is optional, you may or may not. Now, sometimes the myometrium is so thinned out that you may decide to take decidua as a support. Otherwise, what is the suture material that you are using for closure?
Delayed absorbable 1 vicryl.
Vicryl, what is it containing? Vicryl is the band. Polyglycan suture, isn't it? So when you are using it, polyglycan sutures are traumatic. They may cause further injury to the myometrium, which is already thinned out. You may have to reinforce by taking another chromic cadwat. So your principal decidua doesn't matter. Good approximation, I agree. 2.
Then perfect hemostasis has to be achieved.
Absolutely. Hemostasis has to be perfect because there should not be any place where there will be hematoma. Third entity kya hai?
Avoid inclusion of foreign material into the suture site.
What foreign material can come into the suture site?
The vernix and other MSL in case of MSL.
Such a rare thing, no? What about the angles? Have you seen any scar dehiscence or scar rupture? You have not seen a single case?
No.
Where do they usually start happening?
Dehiscence, ones
They are doing all elective C-sections. These are always
dehiscence I have seen, ma'am. Rupture I have not seen.
You have not seen scar dehiscence.
Scar dehiscence? So angle of the wound has to be properly approximated. You should always secure both the angles first and then start suturing. So that one, you will be achieve hemostasis also. Secondly, you will not compromise the angle approximation. And then there should be face-to-face approximation of the layers. Otherwise, what happens? What is the another challenge other than map which you said? There can be a scar pregnancy.
Niche.
And scar pregnancy or niche which gets created, that causes more problem to the patients. Okay. So therefore, that has to be looked into. And suture material, which is the suture material used?
Delayed absorbable suture material.
Are in number?
One vicryl.
Number one.
Number one.
Polyglycolic acid, 910.
Okay. Or you can use
catgut also can be.
Yes, you can consider using chromic catgut in case it's a very thinned out scar. It's a very friable lower segment. Sometimes when you have used drugs such as misoprostol, augmentation, or repeated C-sections, 2, 3, there may be very friable scar. And then polyglycol can be traumatic. So we'll use chromic catgut also. So all these options have to be kept. Our duty is to ensure that there will be proper healing of this patient. Okay. What is the antibiotic policy that should be used for C-section? The WHO recommends one. Government of India has one. What is your policy?
Ma'am, cephalosporins or ceftriaxone 1 gram can be given. If patient is allergic to penicillins, clindamycin can be given.
Are we giving clindamycin?
No, ma'am. No, we're not giving.
Why are we not giving? It's written, but why are we not giving clindamycin?
Because a baby, it has adverse effects.
No, baby to deliver ho gaya na. You can even give it up. What is the one? When should you deliver the antibiotic first and foremost? When should you give?
Before the skin incision, first dose has to be given.
First dose has to be given. I know. Usually it is 1 gram given intravenously. And what is the repeat policy? Do we repeat it again?
That is based on the duration of the surgery and any rupture of membranes.
So any possibility of an infection, then you may consider repeating it. Do you give long-term antibiotic 3 days, 5 days, 7 days?
No,
it is no more given. It is no more given. Hai na? Now you are not using clindamycin. Then what are our options?
Ceftriaxone.
You should read the Government of India antibiotic policy. Do you know there is one? Ministry of Health. So they have included what we use normally. What is it that we are using?
Ceftriaxone.
Ceftriaxone. But ceftriaxone has certain challenges. It's not been microbiologists. Are your microbiologists supporting your ceftriaxone? So they would say cefazolin or cefotaxime. Government of India says cefotaxime, cefazolin. You can also consider using amoxicillin, clavoxin combination if at all these ones are not going to be safe. And in certain places, certain states have also written that you just give one cephalosporin and then you may consider giving a ciprofloxacin TZ combination orally. But unfortunately, this doesn't have any evidence to support what we are doing. So your antibiotic policy also has to be in place and you should not give inadvertently long antibiotics to the patient. That doesn't serve any purpose. What are the long-term complications? Have you seen any scar complications of a C-section? Which we should be very careful. What is first, uske pehle you tell us, what is the dressing care that you will take? Wound health of a C-section, what should be the policy? Because now we are doing so many C-sections, now we better know these things. Na?
Chlorhexidine painting is preferred.
That is at the time of preparation, the wound health and all. After you've done the C-section, how are you going to take care of the wound? How are you closing the wound? Wound closure is done how?
With the subcuticular suture.
Okay. Is there any contraindication for subcuticular suture?
No, ma'am. No.
Yes, there is. You read the data correctly. What is the contraindication? If the subcuticular fat level there is more than 10 mm. Okay, if the subcuticular fat level is more than 10 mm, then you may consider doing taking mattress sutures, interrupted mattress sutures rather than going in for a subcuticular stitching. Okay, so this you have to remember. What will happen otherwise, because there is no place for that, fat undergoes lipolysis, which can give rise to serosanguinous discharge, which can cause infection and a lot of pain. So we may have to consider taking interrupted sutures. Okay. Then what about the dressing policy? When do you pick out the stitches, dressing? Kaisa karne ka?
Day 2 or 3 dressing can be removed.
Yeah.
Stitches can be suture removal done on POD 7, ma'am. 7 or 8.
7 or 8. And what are some doctors are now practicing? They will keep this wound for only 48 hours and keep it open. Some people do that. I'm not very comfortable doing that, but many do it. You know, they want to keep the wound open for better healing and better monitoring. So it depends on what are the patient's hygiene practices, of course. So what are the complications that can happen at the wound? Why was I saying that don't use long-term antibiotics? Too much of antibiotics over a long period of time can give rise to which type of infection, which is a challenge now.
Anaerobic
more than anaerobic infection, there is one terrible infection which affects the wounds, laparoscopy, C-section wounds, where sometimes patients have so much of pressure of the antimicrobial that they may land up in sepsis and die.
MRSA.
One is MRSA. Anything else? So therefore, we stop using that chlor-exiting dipped instruments. We insist that either we have pill pouches, ETO sterilized, or we should put them by autoclaving only. No formalin, nothing. Formalin chamber instruments went out of the window for quite some time now. Which infection? There is another cousin brother which has devastated the reproductive health of women in India. Tuberculous chiloni. Our friend. Okay, so we have to be very careful. If you are going to do all 2, 3 C-sections, 70, 50% of your pregnant mothers are going to undergo cesarean delivery, we will have to have everything in place correctly. Hai na? Yeah, I'm done with my questions. I'll ask.
Thank you, ma'am.
So, post-operative care in cesarean section. And what are the important warning signs that you should be alert? Post-operative care.
Fever, increased urinary frequency, burning, micturition, bleeding, and discharge from the wound site, foul smelling lochia, then paralytic ileus.
Paralytic ileus, that's what I wanted you to say. So why are we so worried about this paralytic ileus? Paralytic ileus in cesarean section. Actually, we have even lost patients. It's one of the dreaded complications. Sometimes everything goes normally, but there are few patients on the second POD with an abdominal distension. So what are you worried about? Apart from internal bleeding and all that, all that within 24 hours we'll find out. But paralytic ileus.
Intestinal obstruction and peritonitis.
If you have forgotten a mop inside, when will it start presenting?
Gossipy myoma, it will start presenting after months, few weeks or months.
Oh, maybe in 4 or 5 days time only she will not have a very nice. So once you have a paralytic ileus, hemorrhage also should be kept in mind, and whether I have left anything inside should be your second option. You know? Yeah,
Yes.
recently I had a patient who came on the 7th day post C-section. She said, I'm feeling giddy. She had a postpartum depression, which I knew, but still we did a sonography, to confirm. You don't know, maybe a placental bit, maybe a mass. And I have seen placenta retained in patients after a C-section.
C-section.
Yeah, so you should re-examine the placenta at the time of delivery, even at a C-section. Because you are very busy delivering the placenta, plucking it out like that. You like to pluck it out like a flower. So,
Yes. So actually, we had a lot of problem. Post-operative paralytic ileus, we had lost a few patients due to that. So one of our dreaded complications.
that is, madam, sometimes because of intestinal handling.
Bowel injury also, it's very, very uncommon in our practice.
Yes.
When you get paralytic ileus, as madam said, you have to look for missed pads and also very remote possibility.
Especially during the COVID period, we experienced this. So post-operative paralytic ileus, madam was apart from that, of course, in the ultrasound we have to see for, madam already told you all this, and of course we have to always rule out foreign bodies.
What about thromboprophylaxis post-delivery in a C-section patient? What are the measures that you should take for preventing TE, thromboembolism?
Adequate hydration. First, we have to categorize the risk based on the weight and age. Then conservative management like limb elevation, stockings, step stockings, early mobilization, ambulation.
When will you institute VTE prophylaxis?
Within 6 to 12 hours post.
With what?
We give low molecular weight heparin, 0.1 ml per kg, subcutaneous OD dosage, ma'am, for 1 week at least.
Post-operative period, thrombosis is very common each day.
Ma'am?
Which period, ma'am? After the surgery, 3rd day, 7th day, 10th day, or 1st day, which day?
Theory.
At the end of 1st week. Normally, the end of 1st week, it's very, very common. That's why we start giving prophylaxis right after the delivery. Which cases would you like to give prophylaxis?
Madam, audio and the clear
Audio clear. இப்ப கேக்குதா?
Okay, madam. இப்ப பரவாயில்ல.
Which cases would you like to give a thromboprophylaxis?
Age more than maternal age more than 30 years, BMI more than or equal to 30 to 35, and comorbid conditions like hypertension, diabetes, preeclampsia, and previous history of DVT, thrombophilia in the family, or then prolonged immobilization.
How will you identify? How will you diagnose? What are the signs and symptoms?
With the help of venous color Doppler, duplex
What are the symptoms the patient will present with? What signs you will elicit? Then what investigations you will do?
Homan sign and Moses sign. Homan sign, pain on forceful dorsiflexion, and calf muscle increase in the girth of the limb, ma'am. Swelling, pedal edema, redness over the side. Then investigation duplex scan, ma'am.
Moses saying we should not elicit, we should not squeeze the calf muscle, which may cause embolism.
How will you manage placenta accreta? Supposing this is a case of placenta accreta.
Ma'am, if it is, can leave it in situ or can do hysterectomy.
To start from even before surgery, what is the ideal time to do cesarean section? it is diagnosed already, placenta accreta, when will you deliver the baby?
Around 37 to 38 weeks.
To wait till 37 to 38?
34 weeks.
Already
Don't know.
Placenta accreta. So you have to decide when to deliver. So you want some investigation to know the extent.
MRI can be done.
So based on that,
Ma'am, if there is no extent.
deciding at 34, deciding at 37 depends upon the amount of
Extension involvement of bladder and bowel cirrhosis.
so it is involving the bladder. Whether it is involving the bladder. Madam is asking when are you going to decide now? Suppose you're going to decide earlier, what are the precautions you're going to take?
For fetal lung, steroids for fetal lung maturity, neuroprotection, and
Steroids, or you want to put something else? Steroids are enough?
neuroprotection also can be.
Neuroprotection. So how are you going to give this neuroprotection?
With magnesium sulfate, in 4 mg in 500 ml oral.
Grams, not mg.
500 grams.
4
grams in 500 ml.
4 grams is loading dose and 1 gram per hour for 24 hours.
Okay. So neuroprotection. Why are we giving this neuroprotection?
To prevent intraventricular hemorrhage.
Necrotize.
Who is answering? I'm not able to make it.
Mahati.
If somebody else is answering, can you show your video also? I do not know who is talking. Is Sherin, who is answering? Okay, you are telling correctly. Please answer.
Mahati, open your video. I think Mahati is answering.
1 minute, ma'am. 1 minute, ma'am. Yes, ma'am.
யாருமே ஆயத்திறக்க மாட்டேங்கிறாங்க.
சரி, okay, அப்ப ஷெரின் தான் பேசுவா போல இருக்கு.
சரி, record ஆகும்.
How will you give neuroprotection? That is madam's question. How will you give neuroprotection?
4 grams of magnesium sulfate in 500 ml of oral at 1 gram per hour, ma'am. Continued for 12.
How many hours?
24 hours.
Up to
24 hours.
24 hours. So why do you want to give this?
Why you want to put 4 grams in 500 ml?
Why?
That is not correct.
What? How will you give? There are better deliverables. No, nowadays you can give it better with that. For oxytocin, IVIS, magnesium sulfate, infusion pump is the better mantra, na? Because you are unnecessarily going to cause fluid overload to the patient. Okay, 1 gram per hour for 24 hours is the RCOG guideline. And then when you stop, when should the patient, how should be the interval from the last withdrawal of the magnesium sulfate to the delivery of the baby? Because see, magnesium sulfate is a very valuable and a useful drug, but has gone in lot of disrepute because sometimes, babies come out, they don't cry. They are nicely breathing, but they will not cry. Crying is important because they have just taken magnesium sulfate. So when you finish the magnesium sulfate, at least have 2 hours of wash of time. And then deliver the patient. Maybe whatever you're planning a C-section or if the baby is going to deliver vaginally, then that's a different thing. But 2 hours usually, then the baby will otherwise come depressed. It's not respiratory depressed, surprisingly. Okay. So all these small things we must know so that we can use these valuable things for better outcomes of our patients.
Yes.
Yes, ma'am.
Was there a Dr. Karbagam? Was there
Yes,
a discussion about the DVT prophylaxis? Did she answer that? What is the care that should be taken to prevent deep venous thrombosis and thromboembolism post C-section? I heard you said the DVT checklist, but what should be the method? Like, how will you prevent it? Did you mention anything?
She told early ambulation. What did you say, Sharin?
Early ambulation, limb elevation, TED stockings can be advised.
And
Passive
if
mobilization.
the score is high, then are you doing the
Yes,
DVT
score.
scoring? Do you do DVT score checklisting?
Yes, ma'am.
See, now all NABH hospitals and everybody has to do this DVT score, okay?
DVT score.
Yeah, there is a DVT score which you have to do in all C-section patients. And if any of these risk factors are there, obesity, preeclampsia, hypothyroidism, all those, there are many things. So if the score comes more, then you are supposed to give them what?
No, low molecular weight heparin has to be given.
Low molecular weight heparin has to be given. Okay. Do you know the dose of LMWH?
Yes, ma'am. 0.1 ml per kg body weight. Usually we give 0.4 to 0.6.
Yeah, but if it's a nice obese patient, 0.4 will not be enough, isn't it? You'll have to give either 0.6 or 0.8. All this will matter, when the patient has pulmonary embolism or something. No? Then we start thinking about lawyers, court, guidelines.
Yes.
So it's always better to be right. See,
Madam,
we
so
have
asking
this
the
kind
question
of a
about adherent
prophylaxis.
Yes, I will send you.
I will send you. Okay, WhatsApp pe bhejna. I'll just put it up in the chat box for you.
So actually, Anuradha madam asked about the adherent placenta. That was the question.
Okay.
When to terminate?
36 to 37 weeks, ma'am.
36 to 37 weeks.
34, 36 weeks, she said, I think, not 37.
So one person said 36 to 37.
Okay.
The next PG. Okay.
Mahati. That is Mahati.
Oh,
Why do you do them prematurely? Anybody can answer this question. Why are we taking morbidly adherent placenta patients earlier for
Early
delivery?
decision. Why is it so?
Invasion is more in term, ma'am. As the gestational age advances, invasion risk is more. So,
Secondly, you may get caught unawares if she starts bleeding in the night. Many times we have lost patients because we were not on guard. And they came in bleeding phase. Okay? Because you require a multi-team approach. Everybody has to be there. So it's always better to plan it ahead of time. And there are many studies which have shown that usually they get into this bleeding phase somewhere around 35 to 36 weeks. So that is the reason why many of us say 34 to 36 weeks we'll plan a delivery.
Yes. Yes, ideally it should be done with all multidisciplinary approach. Morning, ideally morning when you have your chief and all senior assistants by your side. So planning is very important in these cases. Imagine getting caught in the middle of the night. Huh? Okay, placenta accreta. So next. So indications for cesarean hysterectomy.
scar where we're not able to repair.
So that is cesarean hysterectomy or peripartum hysterectomy all? Why? In which conditions you have to do? So you told about classical, so we will go to cesarean hysterectomy.
And there's uncontrollable PPH, ma'am.
PPH?
Irreparable uterine rupture, ma'am.
Uterine rupture.
Morbidly adherent placenta,
Morbidly
it is
adherent
bleeding very
placentas.
badly and you suspect to lose the patient, we can go for cesarean.
It's suppose elective, no? You are planning electively also.
I mean, in case of
There are certain already we talked about accreta.
In case of advanced CA cervix, after cesarean, together we can do radical hysterectomy.
In case of
CA
Creta, percreta, or increta, ma'am.
Accreta, increta, percreta, all these cases. We plan for hysterectomy. So, in placenta accreta, how do you deliver the baby? Now you are going to, we are planning it of course in the morning with all the multidisciplinary approach. How are you going to deliver the baby?
The site of the incision should be away from the placenta, ma'am, and the baby should be delivered without
Ideally, in this case, you should get a consent for
hysterectomy also.
Okay. So it should be away from the placenta. Very good. What would be the ideal place where you put the placenta? So
Classical incision.
So incision should be more on the towards the fundus. Because all the area below will be fully with placenta, and if you happen to go and cut the placenta, that's all. You will never come out of the OT. Okay. So now you have done a classical and you are delivering. How will you deliver in classical? How will you deliver the baby in classical cesarean?
With the help of Bodhana or
Patvadan.
only
In the Patvadan, where will you use this technique?
for deeply
Patvadan?
impacted head.
Your baby is already showing its leg. So tell me about Patvadan
Imagine it's a
technique.
cephalic presentation. That's what madam is asking. It's a cephalic presentation. Head is down below. When you make the incision, it is corresponding to the breach almost there.
Reverse breach, ma'am.
Huh? So what will be easy for you to catch?
The legs only.
The legs. So that is how you are going to deliver. So you told about Patvadan. Since you know about Patvadan, you tell about Patvadan.
Ma'am,
And where will you be using this method of Patvadan method?
ma'am, where the head is deeply impacted into the pelvis. First one limb, the upper limb followed by the same side lower limb, then the opposite side lower limb, the trunk and the opposite side upper limb followed by head.
Lower limb or shoulder? எது எடுக்க போற முதல்ல?
First is the shoulder.
And
then the same side leg, ma'am. Then opposite side, then trunk.
So you have to release the shoulders and then mobilize the trunk, catch hold of the legs and deliver. So Patvadan, it's a very difficult method, should be done in experienced hands. All right. So difficulty in difficulty in delivery of head in cesarean section. What are you going to do?
Ma'am?
Yeah, you have a difficulty in delivering the head. Either it is a jammed head or a mobile head. Suppose mobile head.
First we'll try to fix the head
by giving lateral pressure, ma'am. Then all the
what pressure? What pressure? Your Mahadiya?
No, Rizwana, ma'am.
So in the pressure
from the lateral side, ma'am, and all as well as a little bit of fundal. Then we have to drain all the liquor.
Yes, good.
Which will allow the head to descend a little bit towards the uterine incision.
You engage into your incision. Suppose even then you are finding difficulty.
Forceps can be.
So forceps or
elevators.
One side of forceps or backup can be used. Isn't it? So that is about difficulty in the delivery of the head. It's a real problem, isn't it? All of you are facing. Suppose your deeply jammed head, you already told Patvadan technique. Now you're actually dislodging the head from the pelvis is very difficult. Sometimes when you try this, you may also end up in colporepsis, isn't it? Madam Girija, madam, any questions?
Yes. I just wanted to ask, what about the delivery? You know, she was saying delivery. How can you have a safe delivery at the C-section? You know, what are the important tips? Because all these difficulties arise when the head is floating. Impacted head is easy, but when the head is floating or when you take a long time to deliver that baby. See, many times when you are taking the incision on the myometrium, this is because as a result of what I assist my postgraduates and I experience.
Yes.
You will first take one small thin line on that myometrium. That myometrium goes into contraction.
Yes.
Then you will keep on layering, and then you will, first, I don't know why you like to rupture the membranes. The moment you do that, the uterus will catch hold of the baby, and then you cannot take the baby out.
Yes.
So what should be the principle? You should take the incision 1 inch in the first go itself, and it has to be so properly planned that the membranes will not rupture, and you will be able to take the incision without rupturing the membrane.
Once your incision is widened, then when you are now confident that I am going to grasp the baby, you can rupture the membranes and then immediately hold the baby's hand with all your thumb also going inside, and then allow the uterus to push the baby out.
Yes.
You understand? So that is a very important, that's why your babies get stuck. Secondly, you should always flex the baby's head. Otherwise, in an
Flex and
extended head, if
deliver.
you try to take the baby out, you can't deliver. And then
Angle
there is everybody will have a broad ligament hematoma. How is it possible? I deliver 4 kg baby without anything happening to those uteruses.
Careful
you have to
cesarean
remember.
section. Also, madam, correction of the dextro rotation. That
Yeah,
also they have to
correction of
follow.
the dextro rotation, flexion of the head,
Yes.
nicely rotating. So for that, you should find out what is the position of the baby's head before. You must keep a forceps or a vacuum ready, sterile forceps, obstetric forceps and a vacuum ready on the table. And you must learn to apply them. Because of all you postgraduates, I have become an expert in applying forceps from the opposite side.
Yes, madam. So, see, you please note what madam has said about doing careful cesarean section. It's very, every step is very important.
Very important.
And putting the incision correctly in the lower segment is also important.
Absolutely.
So,
put it at the most widest part of the lower uterine segment. Always. Widest part is where? 1 inch below the reflection of the UV fold.
UV fold.
If you go it very down, then you will definitely injure the descending cervicals at both ends.
Yes.
So this you have to remember always.
Yes, ma'am.
So this is important point. Doing a cesarean, madam has told very important, valid points. It will be useful for you during a cesarean section. So all this you have to follow.
And did we discuss contraception post C-section?
No, we have not discussed, madam, contraception. So what about contraception, ladies? Sherin and Mahadi?
In this particular patient of yours, what will be your contraceptive guidance? This patient, which you presented to us. You know all her background risk, you know whatever you are doing, what will be your guidance?
Permanent sterilization can be offered to her, ma'am, because
I will not agree. Now tell me why I will not agree. I will not agree to permanent sterilization because this baby is only few minutes old baby.
ma'am, then intracesarean copper-T insertion can be done.
Which one can you insert?
I used to be copper-T multi-load or
yeah, we can do a post-placental insertion. That is one. So you should say I can use a post-placental IUCD if the patient has already consented. Any other thing you can do? After 72 hours, what can you do?
DMPA injections can be given.
Tempa can be given. Or even after 72 hours, you can consider doing a postpartum IUCD.
Yes, ma'am.
Right?
Yes, ma'am.
Then anything else?
Mini pills, OCPs.
When can you start the mini pill?
6 weeks post delivery.
What is LAM?
Lactational amenorrhea.
So would you recommend an LARC in this patient? What is LARC?
Long-acting reversible contraception.
Yeah. So what are the 3 important LARCs that we must know?
This copper-T.
Any copper-T is an LARC?
Hormonal insert. Then implants.
So you should say IUCD, IU, intrauterine contraceptive system, or a progesterone. Then
implants.
Marplant or Implanon, that is implants. Okay.
Actually, now government of India now we are giving one injection also.
Dempa. That is one. Even we are giving the not the 150 but the 145 or 135 Dempa. Na? Kuch to. I forget the number. Sampat Kumari madam must be knowing exactly. वो short acting है ना, it's given subcutaneously, not intramuscularly.
Yes.
It's like Dempa only, but it is in a lesser dose. 125, I think it is.
In our Tamil Nadu,
Antara injection.
Antara is very popular.
Antara. That is Antara.
Yes.
Antara is the
So it
government.
is highly accepted among the population. And also we are also post-placental IUCD insertion. Almost for all cesarean.
Yeah.
Even on the table itself in our government hospitals, we are
Dr. Vijay Lakshmi madam is saying that no post-placental IUCD after C-section.
we are doing in the hospitals.
Yeah, we are doing. That's what post-placental IUCD can be put in after.
So after a
But
VBAC,
we-
it can be given, madam.
We have to
After
be
a VBAC.
absolutely doing the
After a
checklisting
VBAC.
correctly. Yeah.
Yeah, that's very important. No, if you are going to do an elective repeat LSCS, it is best to do it post-placental insertion when you are having the uterus, the lower segment open.
Yes.
So you just push it in and then close. That is what is actually being practiced even here.
Yeah,
in-
Pradipti has written here the depot subprovera is 104 milligrams. Thank you, thank you, thank you.
Depot subprovera is expensive. So the Tamil Nadu government's initiative is, as madam was saying, Antara. But the Antara injection, as per the guidelines, should not be given within the first 6 weeks of delivery.
No, it's
Because
after
of-
6 weeks. We give
Yeah,
after
it has
6
to be
weeks.
given only at 6 weeks after
Mostly we
the
manage
C-section.
with post-placental IUCD insertion. After
Yes.
6 weeks, we give Antara. Antara is very much accepted by the people.
Yes. Yes.
And also there is Chaya also. Chaya is also accepted. Centroman.
What is Chaya, Sherif? What is that?
Non-steroidal contraceptive.
Yeah, what is it? Centroman.
Centroman.
Yeah.
Centroman.
SERM. It is a SERM.
It used to be called
So,
saturated
estrogen receptor modulator, ma'am.
How is that given? Saheli or Centroman?
Previously it was under the name of Saheli.
Weekly once.
Now it is
Weekly
become
once oral
Chaya.
tablet. Non-hormonal.
Bi-weekly?
Weekly or once. Oral.
Bi-weekly for the first 12 weeks. After that, you put her on weekly after that. Okay.
Bi-weekly for 3 months. After that,
You have to go.
Now, we are
weekly.
10 minutes past 7.
Yes, madam.
1 minute. Cherin, this armiloxicin, one question. How long he will give? Weekly once for how long?
3 months.
3 months.
6 months. After that, she can become pregnant.
No. 3 months can be given. But
Okay, after 6 months, then you stop this Chaya, what happens?
Then I think madam, she wants to plan her next pregnancy or minimum 2 years.
Just like any other
Hati, don't mumble. You answer loudly. Ormiloxifin, how long you will give?
6 months.
6 months? As a contraception. We're not talking about management of
Okay.
AUP.
Contraception can be given when till when she wants, like spacing when till
Till when she wants to become?
pregnant.
So actually, this Antara has got one benefit. No? It has got a longer effect on the fertility. So even 2 or 3 injections almost protect them for 1 year.
3 days before.
And also, patients need not remember to take tablets. Whereas Chaya, they have to, of course, take once in a week. And it does not provide such a long protection compared to the injector. Madam, Sampath madam, anything else?
Yes, yes. As per practically, this Chaya was given for even for 1 year. Weekly
1 year.
once. That's what I know. We don't have the literature, but for the practical purposes, we are giving even if the patient wants.
எல்லாம் அந்தாரா தான் போட்டுக்கிறாங்க மேடம் சாயா வந்து கேட்க மாட்டாங்க
ஐஓஜில சாயா போடுவாங்க அதனால. So only one last point I want to tell Shireen. Shireen, is there any possibility of delivering the baby rather than from the not through the uterus? Is there possibility for the baby to be delivered through any organ? In which condition it is possible?
car pregnancy, ma'am.
Enema?
Any organ.
Organ, ma'am.
நான் சொல்ற கேள்வி உனக்கு புரியலன்னு நினைக்கிறேன். யூட்ரஸ் வழியா இல்லாம பாப்பாவை வேற ஏதாவது ஆர்கன் வழியா டெலிவரி பண்ண முடியுமா? பண்ணிருந்தா வாட் இஸ் த mistake or what to tell?
Heterotopic.
No,
delivering the baby ன்னு சொல்றாங்க பாரு. Question clear ஆ கேளு.
Previous LSCS.
Previous LS, you open the abdomen, you deliver the baby, but not through the uterus. Because I have seen this case.
Yes, I have also seen that
but not through the uterus.
Bladder, ma'am.
Exactly.
Yes, that is one. If the bladder, if you have full up malfunction, there is.
So what is the feedback of the students? Did they like the session? Did they learn anything?
What, madam? Girija, madam, what you told?
I said, what is the feedback of Sherin and her friends? Did they learn anything?
Yes, ma'am.
Yes, ma'am.
Learn.
Mama.
Yes, ma'am. Yes, ma'am.
See, the whole session is for you people, so you must give a nice feedback. இல்ல ஏதாவது நாங்க improve பண்ணோம்னா நீங்க சொல்லணும்.
Pradipti has written as bladder, but due to fistula, I don't mention it as fistula, but without identifying the lower segment through the incision of the bladder, baby has been died. It is not due to the fistula. Some mistake. So as a PG level, it is not needed, but I want to put a mark. That's all.
Yes, madam.
Bladder pulled up and adherent, and then they just give the incision, and in a hurry to deliver, you just deliver through the
Bladder.
No,
circulation made on the
in the
bladder.
lower segment always. Okay. See, Girija madam was asking, was it useful or not useful? Some comments you can tell no.
It was very
useful,
nice and
ma'am.
informative, ma'am.
Yes.
We felt like we were having.
Anything else you want?
Sorry.
See, we have to improve with each session. So you should give a suggestion on your side whether we have to improve ourselves in your questioning, anything like that. அதுதான் சொல்லணும் நீங்க.
No, ma'am.
இது நல்லா இருக்கு அப்படின்னு போயிடக்கூடாது.
This itself.
சொல்லுவாங்களா? அதெல்லாம் சொல்ல மாட்டாங்க. அதெல்லாம் வீட்ல போய் பேசுவாங்க.
பயப்பட வேண்டியது இல்ல. It's not an exam.
You should know also the guidelines.
Friendly approach. You can ask us.
Now, Tamil Nadu government.
If you have any new information, you can tell us.
Anonymous comments are how to, make it more interesting.
TNFOG mail kuda anupalampa neenga. Whatever you comment, you feel.
Somebody wants a link for the recorded session of this class. Oh, I'm really very happy to know that.
Thank you, madam. Thank you.
We put up on the YouTube, madam. YouTube there is link.
Link for the recorded session of this class. We will see. We are recording, but I don't know whether to give or not, because if I are going to give the link, no one is attending the class. They want to see the recorded session. We will see whether to give or not. Okay. Thank you. Informative, madam. Certain guidelines. Yes, you should know all the guidelines. Gestosis score nowadays in Tamil Nadu also it is followed. Like that for everything, score, checklist, everything you have to know. Thank you, madam. Is there any doubts, ma, Sherin?
Thank you so much.
No, ma'am. Everything is clear, ma'am.
You have to be just careful, and you should always think for the well-being of the patient and yourself consequently.
Yes, ma'am. Thank you so much.
Thank you so much. Thank you so much, ma'am.
How can you reduce the repeat LSCS, ma?
Ma'am, by performing more breech normal deliveries and more number of
The
VBAC.
breech can never be a normal delivery by definition.
Single word. How can you reduce the repeat LSCS?
By
Single word.
reducing primary cesarean
Yes, primary session you have to cut. So you should be very careful in inducing at the appropriate time. Thank you so much.
Primary cesarean you can reduce only if you don't induce.
Isn't it? Ratnamar sir is very strict about that. C-section audit.
So after the audit only, I think the primary section has increased. So we should make it in mind to make all delivery as normal. You should be an obstetrician doing normal vaginal delivery and avoiding hysterectomy. Okay. Thank you. First, I thank Dr. Girija, Dr. Vijayalakshmi and Dr. Anuradha madam for the wonderful discussion. Girija madam, really she very busy. Girija madam.
Nice to connect.
Thank you, Girija madam.
Thank you.
Thank you very much.
It was really interesting. Thank you, Sambat Kumari. Very interesting session.
Yes, madam. Girija madam is very busy. I thought I should call her. She will have LSCS master. So it was really nice. Thank you, Anuradha madam. Girija, we are conducting every second and fourth Saturday.
I love these sessions, but the only challenge is my Saturday OPDs are also running that time.
Oh.
Today, fortunately, I have less OPD because lots of them came yesterday. So I am enjoying. I had one hysteroscopy polypectomy, which my assistant did. I just went into the OT to see what she's doing.
Thank you. So finished two works at the same time. Thank you. Thank you, Anupama. Thank you.
Thank you very much.
Thank you, Sherin. You should be very bold, a little bold. That's all. Okay. Well presented. Thank you.
Thank you, ma'am.
Thank you. Chitrakala, you can stop.
Viji, thank you. Bye.
Thank you.
Ma'am, I will do it, ma'am. The co-host போட்டிருக்கான். சம்பத் ma'am நான் close பண்ணிக்கிறேன்.
Priya, I should thank Priya also who was organizing everything. Priya, close பண்ணிடலாம்.
Close பண்ணிடுறேன். Okay, bye.
Thank you.